Let's pick up where we left off. How do we take advantage of an ultrasound to guide us during an abdominocentesis? Let's start. In the previous video, we discussed that abdominocentesis is best supplemented with an AFAST. What is AFAST? Do you still remember from our discussion on pre-operative assessment? AFAST stands for Abdominal Focused Assessment with Sonography for Trauma. This is a real-time visualization of the abdominal cavity to check for the presence of free fluid, as seen in this ultrasound image, with an initial of FF. Free fluid means there is abdominal trauma, which can range from a leak to a rupture of any hollow organs inside the abdomen, or an internal hemorrhage. AFAST is one of the first things an emergency veterinarian does if he or she suspects for abdominal injury. But do we simply put the probe on the cat's tummy, as seen here, and check everywhere for fluid? No, there must be a system. The AFAST system makes use of the clock face analogy. The abdomen is divided into 4 quadrants, namely DH, or the diaphragmatic hepatic position, which checks for free fluid in between the liver lobes and between the liver and the diaphragm. SR, or the splenorenal position, which checks for free fluid around the spleen and the left kidney. CC, or the systolic position, checks around the urinary bladder and the colon. And lastly, HR, or the hepatorenal position, which assesses the areas of the right kidney and the liver. These positions are assigned as numbers on the clock, starting from the diaphragmatic hepatic position at 12 o'clock, going clockwise. This system prevents any accidental puncture of organs and tissues inside the abdominal cavity. It also localizes the site of injury or trauma. When sticking the needle into the abdomen, or what we call a tab, you might be apprehensive if you will accidentally hit an organ. One fact to reassure you is that mobile loops of bowel, or the intestine, will move away from the tip of the needle once it strikes them. But that does not mean that you will just stick your needle in any abdomen willy-nilly. Oh no. You must always use caution for all patients. One disadvantage is that if the fluid is minimal, and we'll discuss this in detail later, is in between the fluid in between parenchymatous organs, like in the liver lobes or very near the spleen, is quite minimal. Those cannot be sampled because of the sheer difficulty of reaching them and the danger of accidental puncture and bleeding. So how do we use an ultrasound to assist us in doing abdominocentesis? First, you need to localize the specific region wherein there is the free fluid. Second, the free fluid must be on the superficial aspect of the body, on this side of the ultrasound, and must not be obstructed by other organs and tissues, as seen in this image wherein the urinary bladder is obstructing the area where the free fluid is. So how do we move this free fluid up to the most superficial area just beneath the skin? Our technique there is actually to gently shake the body of the patient to displace any tissue on top of the fluid and bring the fluid up. Again, another factor for that is you need to have a significant amount of fluid for that to be moved superficially. Once you've done it, as seen in this ultrasound image, we have moved the free fluid up, the bladder is on one side. A needle is then placed on the lateral side of the probe and directed medially. As it enters the body, you can see it through the ultrasound as a hyperechoic structure. This will help you steer away from the organs and accurately aspirate the fluid of interest. In this image, you can see that this is the free fluid that you want to collect, this is an ultrasound guided thoracentesis. The needle tip appears in the ultrasound as this hyperechoic or white structure. So you could actually see where it is going, and you could redirect and change your direction as you go. In this image of another ultrasound guided thoracentesis, the fluid as seen here is aspirated with a needle tip as seen as this hyperechoic structure right here. So you know if you're going deep enough, and you also know if you can't go deeper because you're gonna hit the lung already. So the ultrasound prevents you from making unnecessary damage to the associated structures. However, this procedure still comes with its limitations and complications. One limitation is when we blindly tap the abdomen and not get any fluids. This is what we call a dry tap. Unfortunately, a dry tap does not mean that there is no abdominal fluid, and you were wrong when you thought that there is. Why? For blind taps, we need to have at least 5 to 6 milliliters of kilo body weight of peritoneal fluid to be able to aspirate it. So if you only have minimal fluid, you will not be able to aspirate it, especially if you're just doing a blind tap without an ultrasound. So you have to factor that in before you actually think that there is no free fluid. Also, you must avoid the caudal epigastric superficial and deep vessels which lie paramedian to the linea alba as shown on the picture on the right. When you are doing a tap, you must not instantly apply suction on the syringe, or technically, wag kang gigil, since this can cause the tissues inside to obstruct the needle because of the sudden pressure and give out a false negative result. The tissues inside, the omentum, the loose connective tissue, could obstruct the hole in the needle if you just suddenly apply suction. So if there is fluid inside, a significant amount of fluid, you could actually see the bevel of your needle fill up with fluid already. Since there are a ton of potential causes of abdominal injury, there's also different kinds of fluids which you can aspirate. You may aspirate blood, chyle, pus, urine, or even air for in cases of a pneumoabdomen, or even a combination of the different fluids. The only way to know for sure is once you get that sample, you centrifuge it, and the cells which settle on the bottom is smeared on a glass slide. You air dry it, stain it with Diff Quick, and examine it under the microscope and check if there are inflammatory cells, presence of bacteria, which is indicative of peritonitis, if there are a lot of red blood cells, and complete this cytologic exam to give you a better picture of what could be happening inside that abdomen. Lastly, abdominocentesis comes with complications like accidental organ puncture, hemorrhage, and sample contamination. So, a little nomenclature lesson. If we aspirate chyle from the abdomen, we call it chyloabdomen. If we aspirate pus, we call it pyoabdomen. What if we aspirate urine? Uroabdomen, correct. So what if we aspirate blood? That's the easy one. Hemoabdomen. But there's this one thing. If you aspirate blood from the inside of the abdomen, how do you know if it is from an active bleeding inside or you accidentally punctured the spleen or a vessel? How do you know which is which? Any guesses? Hemorrhagic infusion or hemorrhagic fluid from a pathologic condition inside will not clot. That's one way to know. It will not clot. However, blood from an accidental puncture of the spleen or of the liver or of a vessel, which is very unlikely, the blood from that will clot. So you have to check your sample if it will clot or it will not clot. If the abdominocentesis revealed an active bleed, meaning the sample that you got is not clotting, what will we do next? Tune in to our next lecture video. See you then! Wait! Before you go, video assignment again. To see a demonstration of how to do the AFAST, take time to watch this. If you are watching this lecture video in YouTube, the link can be easily accessed with a button on the upper right corner of this video. You can easily find this video as well by writing Vet Girl AFAST on the YouTube search bar. Reminder, these video assignments will be integrated into the lecture examinations.